Θα ήθελα να σας καλωσορίσω στο session για την επεμβατική πνευμονολογία. Δεν ξέρω αν ακούγομαι, αν μπορούσα να έχω κάποια απάντηση σχετικά. Ωραία. Καλημέρα λοιπόν σε όλους. Λυπάμαι που δεν είμαι εκεί να σας καλωσορίσω στο session με μια αλλαγή τελευταία στιγμής. Από σχολιαστής είμαι πρόεδρος, αλλά δυστυχώς είμαι online. Παρ' όλα αυτά είναι μεγάλη μου η χαρά να σας καλωσορίσω σε ένα πολύ ενδιαφέρον session με εξαιρετική ομιλήτρια καλεσμένη και εξαιρετικό σχολιαστή που αφορά τις νεότερες τεχνικές επεμβατικής πνευμονολογίας στη θεραπεία των αποφρακτικών παθήσεων του πνεύμονα, του αναπνευστικού. Είναι ιδιαίτερη χαρά για μένα να καλωσορίσω για ομιλήτρια την συνάδελφο Κωνσταντίνα Κοντογιάννη, η οποία διαπρέπει σε ένα από τα κέντρα αναφοράς στον τομέα στην επιστήμη μας στη Χαϊδελβέργη. Κρατάει ψηλά την ελληνική σημαία και τα πηγαίνει εξαιρετικά. Είμαστε περήφανοι για εκείνη και με μεγάλη χαρά θα ήθελα να την καλωσορίσω να μας παρουσιάσει την ομιλία της. Ευχαριστώ πολύ.
Νίκο, κυρίες και κύριοι, ευχαριστώ πάρα πολύ για την πρόσκληση και για το introduction σε αυτό το κομμάτι, σε αυτή την παρουσίαση σήμερα για την επεμβατική πνευμονολογία. Είναι ένα κομμάτι το οποίο το έχω πολύ κοντά στην καρδιά μου και έχουμε δουλέψει έτσι πολύ. Θα με συγχωρήσετε, είναι όλα τα slides στα αγγλικά και η ομιλία, αλλά σχολιασμό και τα λοιπά τα καταφέρνω στα ελληνικά, κανένα πρόβλημα. Λείπω πολλά χρόνια μόνο και είναι λίγο δύσκολο, είναι παράλληλα όλα στα ελληνικά. Θα σας μιλήσω για πράγματα που κάνουμε εγώ δουλεύω στη Χαϊδελβέργη, στην Γερμανία. Ένα μεγάλο επεμβατικό τμήμα. Είναι για μας η καθημερινή ρουτίνα, η επεμβατική αντιμετώπιση της HAP. Και θα προχωρήσουμε εδώ το conflict of interest. Όταν μιλάμε για επεμβατική, για το treatment, το bronchoscopic treatment του εμφυσίματος, έχουμε τρία μεγάλα κομμάτια. Πρώτα είναι το εμφύσιμα and hyperinflation. Μιλάμε valves, vapor ablation, coils and aerosol foam. Δεύτερο κομμάτι, bronchoscopic treatment of chronic bronchitis. Εντελώς διαφορετική θεραπεία, εντελώς διαφορετικό κομμάτι της επεμβατικής πνευμονολογίας, rheoplasty and cryospray. Και bronchoscopic treatment of exacerbations, COPD exacerbations. Και εδώ μιλάμε για targeted lung denervation. Ξεκινούμε από πρώτο, hyperinflation, treatment of emphysema. The beginning was of lung volume reduction in the 50s with surgical treatment. Maybe some of you, I think many of us with HAP, with COPD, they do know about the NET trial, the big trial from the surgeons in the 50s, showing really increased mortality in these patients who have been surgically treated for the COPD, surgical lung volume reduction. This was back in the old days. 50 years later, the first minimally invasive treatment approaches came out. And this means valves. This was the first one 20 years ago. Then coils. We have vapor ablation. We have foam, different approaches, similar principle. The goal is the reduction of hyperinflation. We have two different types of techniques. We have the reversible blocking technique, and this is only one. And we have the irreversible non-blocking techniques, all others. Starting with valves. This is the reversible blocking technique. The goal here is the development of atelectasis. The full atelectasis is a real success of the treatment. We have two different types of valves, the Zephyr valves and the spiration valves. Irreversible non-blocking techniques, almost everything else. Coils and vapor. Until now, there are different airway pathways that we investigate now, but they are not formally and everyday care for the patients. And here we are not going to achieve any atelectasis. We are going to achieve only parenchymal shrinking. And this is the reason why we have to treat both lungs. So one lung, one side is not enough because we don't get the full atelectasis, the full big effect. The last one, relative new, not aerosol. Aerosol is the polymeric lung sealant, the foam that we use. In combination with valves, it's a mixture of both of them. We try with this foam to close the fissure gaps and cause thus CV positive, conversion of positive to negative patients. And then the goal is to implant the valves. I get in detail with every of different kind of treatment. First of all, the valves. You have the spiration valves, 4 sizes, 4 mm, 6 7 and 9 millimeter. And then the Zephyr valves, we have two different sizes, the smaller one and bigger one, 4.0 and 5.5. But also true profiles, we have the low profile and the normal profile. So every bronchus is different. We have to measure and choose the right valve for the right bronchus. This is a treatment which has been really most investigated in this, from these lung volume reduction treatments. Many randomized controlled trials over the last 10-15 years, all of them showing improvement in lung function, exercise capacity, and quality of life. And this is clinically significant in subgroups of patients. For patients, upper lobe, lower lobe, emphysema, doesn't really matter. What we need are complete fissures. These complete fissures are the most important thing in order to have a closed circuit and block a whole lobe, and achieve this atelectasis. So no collateral ventilation. Target lab volume reduction is our goal. So we want to have as much as possible lung volume reduction of the lobe that we are treating, and this is crucial for the outcome. The technique is relatively easy. I have some videos here I can show you. The most difficult part is to choose the right patient. So patient selection for this valve implantation is a crucial step. We need FEV1, of course, we need severe obstruction, FEV1 less than 40 to 45%, and hyperinflation, the minimum of RV 175%. The next question is the emphysema determination. Which lobe can I treat? Upper lobe, lower lobe? Is it homogeneous emphysema? We can treat patients with homogeneous emphysema also by implanting valves. And another important thing is the perfusion, the lobe perfusion. So I need a perfusion scan, a quantitative CT analysis to show me which lobe is the one that's most affected from emphysema, and this will be my target lobe. You see here, for example, this is an emphysema analysis that we do. Everything with yellow is emphysema. So you see here, easy. Both upper lobes are most affected, lower lobes are a little bit more black. Here the other one, here we have homogeneous emphysema. So you see, this is what helps us to determine which lobe, if we have both sides fissures, complete fissures, which lobe am I gonna treat? And of course, exclude patients with findings like nodules, peripheral nodules, or infiltrates, or something that is a contraindication for a valve implantation. Collateral ventilation, the most important thing, fissure analysis. This is done from our radiologists, so they tell us, either visually, they tell us the major fissure on the right side is like 95% complete, so this counts for us as complete fissure. There are better ways, the quantitative CT, which is automated, done from a computer, and they give us percentages like 93.8% complete fissure. It is much more accurate than our eyes. And these are from the radiology, how we see the fissures. Or we do an invasive measurement in the bronchoscopy, collateral ventilation measurement. This is a Chartis assessment. It's done with a catheter. As you see here, there is a bronchoscope, then a small catheter coming out with a balloon. What I'm doing is, for example, if the left upper lobe is my target from the CT, I will block the whole upper lobe with a balloon. And as you see in this picture here, sorry, it's not so accurate, there is a catheter going through this balloon, and the tip of the catheter is open, so the air can circulate. I'm blocking the whole bronchus with the balloon, and I can see the circulation of air, if there is any. In the upper picture, you see it doesn't, I wait for 4 minutes, and it doesn't decrease the flow, the airflow. In the second one, so this is a CV positive, so airway circulation, air circulation, even though that I have really blocked the whole lobe. The second one, the second on the bottom, you see it starts with high flow, and then as the time goes by, it goes down to 0. This is a good candidate for valves. And this is, of course, the invasive but most accurate measurement of collateral flow. Sometimes we don't, our radiologists see 95–98% complete fissures, but there are small gaps which we don't see visually or with a computer. So this is the only way to really exclude the collateral ventilation. Great thing, quality of life. Patients, if they have the atelectasis, we just take away the part which takes a lot of space and it's not really working of the lung, this lobe. So everything that's more healthy, yeah, because COPD is of course and emphysema is everywhere, has more place and we have less volume and the lungs, the diaphragm goes up, the lungs can work much better. It's not only quality of life, it's also survival. And this is a very nice, interesting study from Gombelman showing difference in survival. If you see here in the green patients with without, you see the different with atelectasis and without atelectasis, the difference in 4-year survival, 89.6% for patients with atelectasis compared to 60% with patients after valve implantation without an atelectasis. So survival, not only quality of life, but also survival in those patients where we succeed. Have the first video on the left side. You see the EBVs from pulmonx. You see the valve, it's already loaded in the catheter. I just want to occlude this bronchus in this time. I think we're on the left upper lobe. We already deplanted the first one. I just stay in the middle and load it and implant it on the subcarina, the distal carina. So it's a relative easy procedure. The whole art is to find the correct patient for it. Valve implantation is easy to learn. On the right side of the screen, there are the Olympus, the IBVs, different kinds of valves. You see they have completely different shape. They look like rain umbrellas. Yeah. So you see we implant them the same way. This is nitinol and around this is silicone. So the secretions and air, as you see here, they can come out through this fish mouth. So whenever the patient takes a deep breath, this closes, and when he exhales, the air comes out. And this is the way that we succeed at atelectasis. So the air in the lobe comes out. When the patient inhales again, it closes, so no air comes back. And if we have a closed circuit with complete fissures, this is a way to cause an atelectasis. Same way with the umbrellas, the air and the secretions come through this silicone part out. So we don't have obstructive pneumonias. We shouldn't have. There are always complications, but we are not causing obstruction because secretions come out, air comes out, but it doesn't go in again. So this is the principle of lung volume reduction with using valves. We have the non-blocking techniques. Second one, here we're going to talk about the vapor ablation, targeted segmental vapor ablation. In the beginning it started as a lobar vapor ablation with a lot of then complications because it was too much volume ablated. So we're now talking about segmental parts of the lobe which we treat. And what happens is we know that lung transfer normally the gases from the airway to the alveoli. So it transfers also steam. It's hot. It's causing an inflammation, a sterile inflammation. So we have actually this controlled vapor spray, 3 to 10 seconds maximum, 5.8 calories per gram dose. And we choose in a personalized treatment plan, which every patient gets after doing a special CT analysis, we can see which segments, subsegments of the lobe are most affected from the emphysema, and we go to these sites and just treat them. We don't treat the whole lobe, too dangerous. It hasn't worked well in the past. You see here also a similar balloon like the Chartis catheter, because we want to block so that the steam will not come back centrally. The steam has to go to the alveoli, to the periphery. We block the bronchus, steam comes out. Depending on the volume of the segment that we want to treat, is the time. It can be 3.5 seconds, it can be 8.9 seconds, depending on the volume that we want to treat. And afterwards, we wait until 30 seconds until the steam has distributed. When it's finished, we release the balloon and then treat another subsegment. The problem here is that we, of course, we're not going to cause in this way any atelectasis. What we cause is actually an inflammation. This inflammation, some patients are really worse the first 2 weeks after the treatment. We have to be really careful about having a supra-infection on this sterile inflammation. After this, we have the nice scars that are forming, and these scars cause this lab volume reduction. I have to treat one side, then the next one, not in the same procedure, and we give at least 6 weeks time. Let it settle, see what happened in one side, and then treat the other side. It's only allowed for upper lobe treatment, so patients with bilateral upper lobe emphysema are the perfect patients for vapor ablation. You see how it is. I have here the bronchoscope. I get the catheter inside in the segment that I want to treat, blow the balloon, steam for the time, and then wait and see what happens. This is how the personalized plan looks like. We see here, for example, what's darker is more emphysema. So here I have one RB2 and LB3, possible lobes, segments of lobes that I would treat. We have to think about it. It's irreversible. We cause these scars in the lung, so we cannot take it back. It's independent of collateral ventilation. Doesn't really matter. We have to find the sub-segments that are the best, and this is why we need a high RCT analysis of the patient and also a specialized treatment plan. This is something that the company does and gives us the results, how many seconds we should ablate every segment. Preserved segments are available. So if I treat RB2 and 3 years later the patient comes and has in RB1 much more emphysema, we might then treat RB1 after a few years. So this is something, I have more tissue which I can treat for the future. And as I told you, sequential therapy improves the safety, so not both sides at once. You see one randomized controlled trial, the step-up trial, which settled actually this way of treatment. You see FEV1 improvement over 1 year here in green, and you see St. George's improvement also compared to the control, the treatment arm compared to controlled arm. And you see one patient of this trial, actually this is the ideal patient, it doesn't work that well every time. But you see here before, this we wanted to treat this segment in red. This is baseline CT, and 6 months after the treatment, it's really shrinking, it's much smaller. And the other parts of the lung, so the lower lobe in this case, is expanding, which is more healthier, less emphysema, and can work like this much better. Baseline CT before the ablation, the inflammation that we cause, 3 weeks after treatment. It's really scary. You see it directly after the treatment, the next day actually. Yeah, it's the reaction, that's what we want to. And you see the scars 6 months later, really small. The whole upper lobe is actually smaller, lower lobe much healthier, and now much more place. Clinical observation is very important. We expect a response. We should check the bloods of the patient, CRP, leukocytes, everything should be controlled because a supra-infection can happen, and this is a dangerous part. But actually with supportive care, a little bit of oxygen in the beginning, or antibiotics, prophylactic, if depending on the bloods of the patient, and we release the patients 3-4 days after the treatment and just tell them to be alert and see the first 2-3 weeks. If they don't feel well, they should come in again. So we have the control in the first weeks after treatment is very important. And of course, if we see something, we have to minimize the time of onset to the medical treatment. This is supportive treatment. And there are also best practices recommendations, really nice articles, how we should treat these patients with possible complications. And I have here a video. You see the segment that we chose. We inflate, oh, I'm sorry, you don't see the whole video, but we inflate the balloon, block completely, because otherwise the steam is going to come back. And you see the steam coming out for this period of time, which is for this segment predefined, you see it's getting a little bit whiter, the mucosa. You see the difference because it's like steam, yeah? We're burning it. And release then the balloon, and you see the effects, and this effect goes also to the periphery. This is how vapor ablation works. Going to coils. Coils, we have coils since the beginning of 2010. Now we are causing lung volume reduction by compressing the lung parenchyma. So we implant the coils, and these are small nitinol coils. They are elastic. They have this form in the beginning, here. And we insert them in the bronchoscope straight, in also a catheter. And once we release them, they take this shape again in the lung, in the periphery. And in this way, it takes a small parenchyma, part of the parenchyma, and pushes it centrally. So we have a small lung volume reduction with each coil. We need at least 10 coils per side. We have also to treat both sides here, no atelectasis, so small parenchyma shrinking with mechanical pressure compression from coils. So this is the way that we achieve this lung volume reduction, and once one side and then the contralateral. This is what I told you, like we insert this catheter, the coil is straight in there. After we release it, it takes the predetermined form and pushes and pulls the lung towards the center. You see unilateral coils in an X-ray here on the right side, on the right upper lobe. Bilateral treatment, the coils stay in. It's also irreversible. Some coils we are able to remove, but it's actually, you cannot remove 10 and 20 coils from a patient. This is considered an irreversible technique treatment. And you see here with the fluoroscopy, because we need fluoroscopy, when we insert the coils, we have to avoid the pleura. If we are too close to the pleura, we will cause pneumothorax, because pleura comes with. Yeah, so we have to measure the distance from the pleura and start one after the other coil until we have the amount that we need. Randomized controlled trial, also for coils, showed an improvement in quality of life and RV reduction, but for a subgroup, a special subgroup. These are the patients that profited, patients with high RV, more than 225, so 200 is not an indication for coils. This patient will not improve and benefit that much as the patients with really high hyperinflation, and it could be heterogeneous, it could be homogeneous emphysema, this doesn't matter, but they have to be really hyperinflated. So this is a treatment option for patients with severe end-stage COPD with no other treatment options, and also with incomplete fissures. Now this fissure is also irrelevant in this case. There are 3 generations of coils. We have the first one on the left. This is how it started, the pneumaric coil. Then we have the LifeTech, the Kinensis. There were also studies with these coils, look a little bit different, have also silicone covering around. And this is the 3rd generation on the right, the free flow coils. They have 2 anchors, not only one. So with each coil has 2 anchors and grasps double as much volume parenchyma as the first ones. I have here a video. Hope it works, yeah. So you see the catheter, we touch the pleura and measure, make sure that we are in a safe position away from the pleura. And you see we leave the catheter inside and then we introduce the coil. You will see it coming. These are the free flow, the new generation. This is why you see the 2 anchors. And you will see them slowly coming out. And then taking the form and grasping a lot of parenchyma and pushing it. As we release the coil, we push it, take it centrally, and then release it from the bronchoscope, and then it stays there with pushing the parenchyma closer to the center of the lung. Very, very important point, of course, high hyperinflation. These are the patients we said already. But on the right side, we should never, in these COPD patients with this emphysema, we should never implant coils. Coils need parenchyma. Here they're going to cause a pneumothorax with the first coil. So these patients are really excluded. You need parenchyma and still high hyperinflation, so it's not very easy to find these patients actually. But please avoid something like this. Irreversible, yeah, independent also of collateral ventilation. And as we said, there are randomized controlled trials which show this improvement, clinically significant only with RV higher than 225%. We need much more studies with bigger patient numbers to close, really, to make good statement about coils. Going to the mixed one, to the foam, you see here AeroSeal system. This delivers a polymer foam. I say it's like, it looks like, in the beginning it's a foam and then it will get harder like cement. So it's actually, we install this foam, and what we want to do is, if you see here, this is how it looks. We have two different bottles, we mix them together, and then we have a few seconds to install it. Otherwise it's gonna get really hard. And what we want to achieve with this is go to this point of the fissures where there are the gaps of the fissure according to the CT analysis, and close these gaps. So it's not anymore, it used to be a treatment for lung volume reduction, just a lot of foam in there and cause also an inflammation. But now we try with this small local inflammation to close the fissure gaps. If you see here on the right, this is, for example, the gap in the left major fissure. We install in this sub-segment the foam and try it, think about it like cement, really, like a wall. Try to create this wall there, so close the gap of the fissure. There are studies running. We have the CONVERT trial 1, it's already finished. They try to see, to show this CV conversion from positive of negative on negative. This means we have to do a Chartis measure before, make sure that the patient is positive, so he has an airflow, install the AeroSeal, let the patient come a few weeks later, repeat this measurement, and then see if that it converted to negative. When I have a negative Chartis measurement, I can implant valves. I have the problem solved with the fissures, so the next step is valve implantation and cause of atelectasis. It works well in this study so far. The second CONVERT trial 2 is running now with much more patients, much more centers in Europe. This is how it looks. It's like a catheter with this fluid foam, which will become within a few seconds really hard. Afterwards, we measure a few weeks later the Chartis. If it's negative, valves come in, that's it. Also really promising. We'll have to do we'll see the results of the second CONVERT 2 trial and then decide. Leaving the severe emphysema and hyperinflation patients and going to the bronchoscopic treatment of chronic bronchitis, so patients, they don't have to be inflated, they have to have only this chronic bronchitis. We have rheoplasty and we have cryospray. You see here in this really nice sketch, and we all know the big goblet cells, the thick mucosa producing a lot of sputum, a lot of secretions in chronic bronchitis. There is a balloon disobstruction. There is a publication about it. We don't have that much data. This has been done in Turkey. We have bronchial rheoplasty, which we're going to talk about this. We have the cryospray, and we have the vagal nerve ablation, which is actually, it has been started as chronic bronchitis treatment, but now it's COPD exacerbation treatment, actually, because they have seen that these people have a better, less exacerbations after the treatment. What is our goal? We want to destroy the mucosa, we want to destroy the goblet cells and give the chance for new healthy cells to grow, so not completely burn them, not completely destroy them, but destroy the abnormal cells and then give a chance to the normal to grow back and have less secretions and have healthy mucosa in patients that have already stopped smoking, of course. Otherwise, there is no sense in this whole treatment. So what is the bronchial rheoplasty? This is a catheter which gives pulsed electrical fields. This is an RFA actually treatment. Non-thermal electrical fields are applied on the epithelium. You see, we go really The ablation zone is deep to the cartilage. So we ablate the whole mucosa, submucosa, and go deeper where the glands, the submucosal glands are, also very important for the sputum production. And the goal is to ablate the abnormal mucus-producing cells, as I told you, non-necrotic epithelial and submucosal cell death. This is what it does. It's not fire. We're not burning it. And we have everything else there so that we can expect a healthy regeneration of the epithelium. It uses monopolar electrode. This means that patients who have cardiac devices don't come in question for this treatment. CE marked 2019. All of these treatments have a CE marked. So actually we can do it without a clinical trial. Two separate treatments, and once one lung and then the other one, and now we are not talking about, because chronic bronchitis is everywhere, so we have to treat the whole lung, upper lobe, lower lobe, we treat everything as much as possible. This is how the catheter looks like with this basket here, and the electrical impulses come through around 360 degrees and are installed there locally. It takes about 40 to 70 activations. I would say also 90. The more the better. This means we go to the periphery and then come back slowly and try to treat as many subsegments as we see. The more the better. And general anesthesia takes a little bit long, and it's a boring procedure, to be honest, because you have to just stay there and wait until you have done everything, or as much as possible. About 60 minutes, 40 minutes, the more you do, the better for the patient, so it takes a lot of time to treat one side. Break for 6 weeks, patient comes then later for the second size, for the second treatment. We do it with general, we have rigid scopes, you can intubate the patient, whatever. You see the normal bronchoscope, we need a minimum 2.8 working channel so that the catheter fits through, goes through, and you see the generator of this impulse. We have the electrodes and we synchronize it with a ECG. So whenever he has a beat, then it gives the electrical field. This is how it looks like. This is the top of the catheter. We insert it in our working channel. And you see, not that well, but you see on the balloon on the tip, the basket, sorry, not balloon. And on the other side, going in the bronchus, try to go as deep as possible. You have to see, of course, the basket, full diameter, and then you don't hear it, but it's a few seconds, you stay there, and then when the generator is finished, it makes a noise, and then you know it's finished, and then go back, come to the next segment. You have to be really careful knowing that you're not treating every time the same segment. So you have to know the anatomy and remember where you have been. It's not bleeding. So this is a nice thing to do. I will tell you our own experiences. They are not published yet, but we have really great results. So people coming later, the patients, and saying like, I'm not coughing anymore. Patients that are coughing and have a lot of sputum, no complications, really good result, but this is our experience. We can give periprocedural steroids. It's a long procedure. We give one shot, 25, 50, depending. We can. This is also our clinical experience. We do a prednisolone for 5 days, so that we will not cause a huge local reaction. Ευχαριστώ πολύ. And periprocedural antibiotics. Many studies running, US, America, everywhere. Some results have been published. CAT score improvement, St. George improvement. And interesting, you see here the goblet cell hyperplasia score before and after, 3 months after treatment. So you see here the big goblet cells, and you see the patient after 3 months later, they're gone, 39 mean reduction. So this is the great result of this study. Cryo, same thing, same principle. We just want to destroy the goblet cells. We spray minus 90 degrees or 96, and with liquid nitrogen cause this destruction of cells with this extreme cold. We don't go that deep as rheoplasty. You see, we stay here until the submucosa. and wait and see the reduction of sputum in the patient. Again, both lungs, 3 treatments in this case, twice the upper lobes and then once lower lobe, right, left, and then both upper lobes. Many studies so far, lobectomy histology, safety studies in the beginning, and the first randomized controlled study with 35 patients only, but it's something that's running in England, in London, showing good results. Of course, adverse events, feasibility, and the data shows also improvement in St. George, improvement in CAT score, and in all different questionnaires that the patients got with no device or procedure-related serious adverse events. Safe treatments, giving really a good quality of life to the patients. The last one, targeted lung denervation. It started like a chronic bronchitis treatment. They have seen in the first studies that these patients decrease extremely in the amount of exacerbations afterwards because they are all severe COPD patients. And what we do is ablate the lung vagal branches. So we know that they are in the 2 main bronchi on the left side and on the right side. We go with an electrode, as you see you see here the electrode, and just ablate in 360 degrees. This is RF energy. This is how it works. We have a balloon with this electrode. You see the electrode here, yeah, and the balloon. So we have to blow the balloon. We have to make sure that it has good contact, and we just give the energy. And inflate, deflate, activate, and do this 4 times so that I have all 360 degrees, once on the right side and then on the left side. This is one procedure, taking a long bilateral treatment, taking a long time, also about an hour. It's not easy to have the good contact with the electrode. Different studies, the airflow 1, 2, 3, we are enrolling was completed, and we are waiting for the first results. You see here the decrease compared to the sham control, decrease in exacerbation risk and hospitalization risk for those patients, 600 days. It's a huge decrease in exacerbation rate. Very important, stay safe away from the esophagus because the esophagus has also vagus branches. So if we ablate the esophagus nerve from the esophagus, the vagus, then we have dysmobility, we have another problems from coming from the esophagus. So we measure the distance from esophagus and make sure on the left side and make sure that we stay away. So we leave esophagus away. Coming to the last slide, correct therapy for the correct patient, correct time, and for the correct results. This is highly personalized, the interventional treatment of COPD. And this is what we say, specialized centers, patient selection is the most important, not really the whole, how do you implant the valves. This is an easy thing. And that's it. Thank you very, very much.
Ευχαριστούμε θερμά την κυρία Κοντογιάννη για την εξαιρετική πλήρη παρουσίαση, ξεκαθαρίζοντας τη μεθοδολογία αλλά και μοιράζοντας τη δική της εμπειρία από το κέντρο στο οποίο ουσιαστικά κινεί και εξελίξεις πάνω σε συγκεκριμένα θέματα χρόνια τώρα. Θα ήθελα να δώσω το λόγο στο σχολιαστή, τον συνεργάτο, συνάδελφο κύριο Βίτσα, να κάνει ο ίδιος ένα σχόλιο και να με βοηθήσει και εμένα στο κομμάτι των ερωτήσεων από το κοινό από εκεί και πέρα. Λάση.
Πρώτα απ' όλα να πω δεν στην πήρα εγώ τη θέση, μου το ζητήσανε και κάθομαι εδώ που θα έπρεπε να κάθεσαι. Αυτό. Δεύτερο, θέλω να πω ότι πολλές φορές βλέπουμε αυτές τις παρουσιάσεις και συγχαρητήρια για την παρουσίαση. Πρώτα απ' όλα να πω που προσπάθησες να μαζέψεις σε μισή ώρα όλα αυτά που παρουσίασες πέρσι στο ERS σε 4-5 ομιλίες. Δεν θυμάμαι πόσες ήταν για να τα πεις όλα αυτά.
Είναι λίγο δύσκολο, είναι τα basics.
Αυτά ήταν τα βασικά στην πραγματικότητα. Αυτό που στην ελληνική πραγματικότητα μας ενδιαφέρει είναι λίγο οι βαλβίδες να μπορέσουμε να τις βάλουμε στην καθημερινότητά μας. Συνειδητοποίησα ότι όσο μιλούσες, Κωνσταντίνα, ότι έχουν περάσει 10 χρόνια από τότε που ήρθα εγώ για εκπαίδευση στη Χάιντελβέργη και εσύ ήσουν ήδη εκεί και δουλεύατε σε όλα αυτά τα πράγματα. Επιβεβαιώνω όλα αυτά που λες, γιατί επειδή γνώριζα γερμανικά, μου δίνανε να κάνω πράξεις, έβαλα βαλβίδες, έβαλα κόλληση, έλα να βάλουμε εκεί, να βάλουμε άλλο. Τι ωραία, λέω πανεύκολα. Φέρτε μας τις βαλβίδες να τις βάλουμε. Και μετά ήρθαν ο Έμπερχαρτ και ο Χάρ και μου λένε: έλα να κάνουμε λίγο τα εξωτερικά ιατρία, αφού καταλαβαίνεις λίγο τα γερμανικά, για να δούμε λίγο πώς διαλέγουμε τους ασθενείς. Και κατάλαβα πόσο δουλειά υπάρχει πίσω από το να διαλέξουμε τον ασθενή, για να φέρουμε αυτήν την θεωρητικά εύκολη στα καλά χέρια μέθοδο, η οποία είναι πολύ ακριβή, και ότι αν δεν το διαλέξουμε καλά τον ασθενή μας, την έχουμε κάψει αυτή την τεχνική, γιατί δεν θα λειτουργήσει, θα έχει μόνο παρενέργειες. Και ως συντονιστής της ομάδας επεμβατικής πνευμολογίας της Ελληνικής Πνευμολογικής Εταιρείας, να πω ότι μάλλον από εκεί καταλαβαίνω ότι πηγάζουν οι δυσκολίες του να πάρουμε την έγκριση του να μπορούμε να βάλουμε βαλβίδες στην Ελλάδα. Το δύσκολο selection και η ακριβή μέθοδος τους κάνουν όλο πολύ διστακτικούς, αλλά όπως και στη Γερμανία, που δεν βάζει ο καθένας τις βαλβίδες και τα κόλληκα, αλλά πηγαίνουν ως referral σε εξειδικευμένα κέντρα, έχουμε προχωρήσει πάρα πολύ. Αυτά είναι τα ευχάριστα νέα που έχω να πω, ότι σιγά σιγά μάλλον θα πάρει έγκριση πρώτα ένα κέντρο στην Αθήνα, να μπορέσουμε να πάρουμε σε δημόσιο νοσοκομείο μέσα όμως από μια επιτροπή που θα αποφασίζει ότι ναι, αυτός είναι ασθενής για να πάει να πάρει τις βαλβίδες. Και μετά από πολύ καιρό, μάλλον είμαστε σε καλό δρόμο. Πολλές φορές το έχουμε πει, αλλά υπάρχει και μια πολύ μεγάλη πιθανότητα στα επόμενο ένα χρόνο να μπορέσουμε να κάνουμε refer από τους ασθενείς μας και να μπορέσουμε να τους έχουμε, να τους δούμε και με βαλβίδες ως αρχή. Αυτό είναι το.
Ήταν σούπερ, πραγματικά, και νομίζω ότι είναι ένα κομμάτι που η πνευμολογία είναι πολύ πίσω. Οι καρδιολόγοι έχουν πολύ ωραία τα διουρητικά και τα όλα, αλλά έχουν και την επεμβατική καρδιολογία. Και πλέον δεν νοείται χωρίς η θεραπεία της καρδιακής αναπαραγωγής. Είναι και η επεμβατική καρδιολογία.
Εγώ καταλαβαίνω το δισταγμό του δημοσίου, να πω την αλήθεια, γιατί είναι λίγο δύσκολο. Φαντάζομαι ότι αν απελευθερώσουν, ναι, OK, πάρτε τις βαλβίδες που κάνουν 10.000 ευρώ, βάλτε τις όποιος θέλει. Θα βάλουμε βαλβίδες και στα χαϊπουργία, δεν ξέρω να πω τώρα κάτι.
Αυτό πρέπει να είναι απόλυτα.
Αλλά η αλήθεια είναι ότι όπως και στις μεγάλες χώρες, υπάρχει ένα εξειδικευμένο κέντρο στη Χαϊδελβέργη, τα παρουσιάζουμε όλα αυτά, αλλά από πίσω υπάρχει τρομερή δουλειά για να διαλεχθεί αυτός ο ασθενής. Που πας 1-2 μήνες πόσο πήγαμε και τους έβλεπες να μπαίνει ο ένας μετά τον άλλον και να παίρνουν ακριβές θεραπείες και τεχνικές να χρησιμοποιούνται πάνω τους, αλλά από πίσω υπήρχε πάρα πολλή δουλειά και φαντάζομαι για τον κάθε ένα που διαλέγανε, άλλοι 50 απορρίπτονταν για να μπορέσουν να το κάνουν αυτό, και θέλει εξειδικευμένο πράγμα. Νομίζω ότι θα φτάσουμε κι εμείς σιγά σιγά, όπως και σε όλες τις τεχνικές. Εκεί που ήμασταν όλοι πολύ απεσιόδοξοι, και κοντίνι υπάρχει στην Ελλάδα και όλα τα νοσοκομεία σχεδόν έχουν πλέον έμπους, που τα βλέπαμε λιγάκι τότε και λέγαμε πως θα έρθουν ποτέ στην Ελλάδα. Θα έρθουν και αυτά, αλλά πρέπει λίγο να είμαστε αισιόδοξοι.
Ευχαριστούμε πολύ. Επειδή είμαστε λίγο πίσω στον χρόνο, μήπως υπάρχουν κάποιες ερωτήσεις από το κοινό που πρέπει να απαντήσουμε για στο λίγο χρόνο που ήδη έχουμε ξεπεράσει άλλωστε?
Ό,τι θέλετε, mail. Έχουμε mail, ό,τι χρειάζεται.
Νίκο, τους βλέπω λίγο κουρασμένους. Τους τα πάμε πολλά.
Ωραία. Τότε και προς σεβασμό και στο επόμενο session θα ήθελα να ευχαριστήσω θερμά όλους για την παρουσία τους. Απολογούμε που δεν είμαι, αλλά έχω κάποιες επαγγελματικές υποχρεώσεις που δεν γινόταν να αναβληθούν. Θα ήθελα να ευχηθώ καλή επιτυχία στο συνέδριο, στην Οργανωτική Επιτροπή, στον κύριο Τιτόπουλο, στον κύριο Τρίφωνα, και καλή συνέχεια σε όλους. Ευχαριστώ πολύ.